Good afternoon, everyone, and welcome to our July CDPH and CMA virtual Grand Rounds. I'm Dr. Kim Newell-Green, and I'll be the moderator for today's session on tick-borne disease. The goal of this series, as a reminder, is to bring emerging public health issues in our state to the forefront in just-in-time education. Next slide, please. We so appreciate Dr. Erica Pan, MD, MPH, for continuing to make time for us, even with her new role as Director and State Public Health Officer for CDPH. Following Dr. Pan, we'll hear from Dr. Ann Kemptra again this month, and newly Dr. Gary Green, to help us understand the evolving landscape of tick-borne illness in California. As our patients explore the natural environment of California and travel to other states in the US this summer, many will be exposed to ticks and the range of diseases that these insects can carry. And many of us as clinicians have questions about testing and treatment, and our speakers will begin to help us answer those today. Next slide, please. Today's slides are available for download, so this shows you how to do it. Next slide, please. These are our speakers' disclosures. Next slide, please. As a reminder, this series is accredited for CME credit. You'll be sent a survey after the completion of the webinar where you can attest your attendance, and upon completion of that survey, we'll send you your certificate, so don't forget to do that. Next slide, please. That's the CME learning objectives. And next slide, we can go ahead and start with Dr. Erica Pan. Erica, again, it's great to have you as always.
Great, thank you so much, Dr. Green. It's great to be here again, and there's certainly a lot going on in public health. Next slide. Let's go ahead to the next slide. So I'm going to talk to you. I'm going to try to, in just a few minutes, breeze through some. I know a lot of people, or at least certainly we are really tracking very closely the ACIP updates and what's been happening there. A little bit about trends with COVID and summer COVID. And then there's a lot happening with impacts of public health funding cuts. So just a few tidbits there and some resources and references to point you all to, because I do want you all to know, I know Medicaid cuts are the biggest top of mind to our healthcare provider system and partners, but I also just want you to be thinking and knowing about what's happening on the public health side as well. Next slide. Next slide. So the Advisory Committee on Immunization Practices, as you all know, has had a lot of changes recently and did meet recently. The 17 prior members were abruptly terminated, and there were 7 sort of remaining. So I wanted to just give you a few concrete highlights about what's happening there and how that early information on how that impacts us as for you all as providers and in California. But just to walk through concretely a few of the actual votes that went through and that were discussed. As far as RSV, clesrovimab was recommended and passed for all infants less than 8 months of age born during or entering their first RSV season. And this was approved to remain in the vaccines for children to be added to the options in the VFC options for RSV prevention. So that is, I think, good news, especially seeing there was a lot of great data shared as you look at those slides and presentations on the huge impact we saw last season of having more prevention for RSV and more monoclonal antibodies and vaccines. So next slide. They also did reaffirm the votes for routine annual flu vaccine for all people aged 6 months of age and older who don't have any contraindications. So that was also voted on. And there were some updates on just updating the vaccine composition as they do every year, looking at which strains have been circulating and having trivalent flu vaccine. FluMist was also an update this year. So many of us remember that many years ago when we had the intranasal vaccine, and now it is back. And that can be actually done by individuals themselves or by caregiver administration. And there was also a change in the age indication for Flublok from only adults 18 years and older to over 9 years of age and older. So again, more details are in all of these links. Next slide. And then there was a discussion added to the agenda about thimerosal-containing influenza vaccines. And there was a vote saying that flu vaccines that only flu vaccines in a single-dose formulation that don't have thimerosal as a preservative are recommended by the ACIP. I just want you all to know here in California, we've actually had a law in place that prohibits administering mercury-containing vaccines to pregnant women or children less than 3 years of age, and all routine vaccines are available in formulations that meet the law. But we also want to emphasize that a lot of that was previously recommended, and a lot of the changes in the vaccine supply were before later studies that show that thimerosal specifically is metabolized differently and does not have a risk similar to what the prior concerns were. So the National Foundations for Infectious Diseases also had issued a statement in response to this that there are non-existent risks of thimerosal in flu vaccines, pale in comparison to the real risk posed by flu each year in the US. I will just mention that there's probably only about 5% of the flu vaccine supply is in these multivalent vials, multi-dose vials. And again, that's a preservative there so that you can maintain sterility and have, multiple doses in one vial as opposed to single dose vials. So many of you remember during logistics and operationally, sometimes when you are trying to vaccinate a large number, or in some rural clinics or clinics that don't have as much volume vaccination, it's more sort of efficient and cost effective to have multi-dose vials. So it is a smaller proportion of our supply, and those situations are, again, often in clinics that have smaller volume. And so there are some concerns about equity and many providers have already ordered multi-dose vials. So that is sort of the update on that. And there's also a statement, next slide, just to show you kind of what the FDA had previously shown about vaccines recommended for 6 years of age and younger, that there are available formulations that don't contain thimerosal, and that, again, there's a robust body of peer-reviewed scientific studies conducted in the US and other countries supporting the safety of thimerosal-containing vaccines. And again, as I was mentioning, in these multi-dose vials, these preservatives prevent microbial growth. You also see this in contact lens solutions and other types of products that we use as well. So this was brought up again, as mentioned, but just that FDA statement, at least as of the time we downloaded this, was still there on the FDA site. Next slide. And then shifting to COVID, so they did not vote on COVID-19 vaccines as far as approval recommendations for the 25-26 season. As many of you know, and another slide will touch on this, the Secretary of Health and Human Services and the FDA made some updated statements and opinion pieces in medical journals around COVID-19 and not recommending it. Actually, there was some contradictions and confusion because it was recommended for people at serious risk, which includes pregnant women, but then it was stated that COVID-19 vaccine is not recommended for pregnant women. But I wanted to show you the data. This is from also the ACIP meeting, and then your local epidemiologist, Caitlin Gittolina, in her newsletter also did a nice kind of pull out of that data with some extra notes. But just wanted to show you that infants less than 6 months of age have the same hospitalization rate as 65 to 74-year-olds. And certainly the highest risk are people over 75 years of age. And then you can also see here that in the 6 to 23 months of age group nationally, that risk is similar to 50 to 64-year-olds as well as far as hospitalization. So just kind of highlighting nationally what we know about the severity of COVID hospitalization rates in young children and in infants. Next slide. So I already kind of mentioned there have been some confusing questions, confusing recommendations. ACIP did not yet vote on this. There's a potential meeting coming up in August or September where it may be put on the event agenda for 25-26. What we're currently using is still 24-25 recommendations, which have not changed. So our department, California Department of Public Health, still recommends that all individuals 6 months and older should have access and the choice to receive currently authorized COVID-19 vaccines, and they are still currently authorized from the 24-25 season, with an emphasis on protecting higher risk individuals. So certainly, you want to emphasize and in the elderly, in pregnant individuals who certainly are at higher risk for severe disease, infants and toddlers, and others with medical conditions at risk. And then currently insurance coverage for COVID-19 vaccines is still in place. I'll talk in a few slides about the landscape of where we point to ACIP in national and state laws and coverage. Next slide. The other thing that came up was announcement of some new work groups. There is going to be a new work group looking at the cumulative vaccine schedule review, and some statements around concerns around the number of different diseases we prevent and the antigen exposure. So that is potentially a new work group that's been announced. There also has been a recommendation by the new ACIP to re-review vaccines that have not been reviewed in over 7 years. And clearly they were highlighting they wanted to talk more about hepatitis B at infancy. And then there was some discussion about MMR combination vaccine with varicella and the potentially increased risk for febrile seizures in the younger ages. So that was discussed but not voted on, and that will probably come up in these work groups as well. And then for time's sake, I'm not going to talk about the discussion that they had also on chikungunya and anthrax vaccines. But again, these links will give you all that additional information. Next slide. So this is a great slide, courtesy of Epstein Becker Green, which is a law firm that actually has some expertise in vaccine law. And this is just kind of a highlight of the federal laws that relate back to ACIP recommendations. The ones I wanted to highlight the most for all of you are in this middle column here. So in the Affordable Care Act, in coverage of prevention health services, that is where it is required that ACIP recommended immunizations are required to be paid by private payers. And then also for in VFC as well, the VFC program points to ACIP recommendations as far as what is included in VFC, which covers about half of the children in California get their vaccines from the Vaccines for Children program. So that is where we and national partners are looking really closely at what could change if ACIP recommendations change. I think specifically around private payers, and I'll mention this again later as well, but the health insurance plans of America have issued a statement supporting their supportive vaccines. And can people please mute? Thanks. And then some other details in here as well about other places nationally where ACIP is referred to in our national codes and laws. Next slide. Here in California, just some quick high-level highlights as well on where we have laws that are relevant to ACIP recommendations. School entry requirements actually reference vaccines individually and do not refer to ACIP. So this will not impact any of our school and child care vaccines. As far as medical exemptions, they reference ACIP and AAP and AAFP, who I'll sort of show you links later as well, continue to recommend, for example, and it's not relevant to school entry, but AAP and AFP are continuing on sort of their support for vaccines and have issued statements as such. As far as pharmacist vaccination, we do have some state scope of practice laws around pharmacists can vaccinate FDA authorized and ACIP recommended vaccines for individuals 3 years of age and older. And probably based on our immunization registry, about a quarter of our vaccines administered in California are administered by pharmacists. So we are looking at this as far as what might need to be addressed or modified around this if we have concerns about the number of ACIP recommended vaccines, if we believe the evidence and science still promotes the use of those vaccines. As far as specific settings and populations, there's some language in SNF standing orders for flu and pneumococcal vaccines as recommended by the ACIP for those over 50, and then CalWORKs recipients are required to have awareness and education for ACIP recommended vaccines. And then as far as insurance coverage, Medi-Cal private plans and disability plans do have some language in there about ACIP. Some of them say ACIP and other medical professional organizations like AAP or AAFP. So we're looking closely at that in California, and again, looking at ways to address if there are changes in ACIP recommendations that we don't believe align with the scientific evidence in prevention and how we can address that. So stay tuned on that, but just so you're sort of aware where those changes could have impact. Next slide. So we're closely monitoring all these things. There is, as I mentioned, another meeting planned for probably August or September, and there may be discussion of COVID-19 formal recommendations then. I mentioned the new work groups. A lot of the existing work groups, a lot of individuals that we work with closely have been canceled, and we're just not sure if they're going to be canceled permanently. But a lot of those meetings have been canceled. There has been no communication that I'm aware of where the work groups have been formally dismantled, but we're watching that closely. Similarly, there are 31 liaisons to other different public health and medical professional organizations, and they were allowed to participate virtually as usual in this last ACIP meeting, but we're not sure if there are going to be changes made to liaison roles as well. I will just share that there has been national alignment from multiple medical professional organizations, pediatrics, family practice, AMA, IDSA, the American College of Physicians, the National Academy of Medicine, and I already mentioned the insurance plans have been issuing statements supporting vaccines and the use of vaccines and scientific-based recommendations. Many of you may be aware, but just to highlight as well, the Center for Infectious Disease Research and Policy at the University of Minnesota has launched a vaccine integrity project, and they plan to publish a comprehensive scientific brief before the respiratory virus season this fall and winter to really summarize scientific evidence that could inform these medical professional recommendations who have often had sort of specific recommendations about their populations. There was also just some litigation filed by several of these organizations yesterday to the Secretary of HHS around vaccine policies. So we'll be staying tuned on all of those things as well. And again, looking specifically in California on how we can address reimbursement and scope of practice issues around referring to ACIP. So again, we'll keep you updated as that evolves. Next slide. And I'm realizing, anyway, so next slide. So COVID-19, there were some questions, and that was one of the main things I was asked to address. We definitely are seeing an uptick in the summer. It's still relatively low compared to, for example, last year around this time when the test positivity was 8.2% versus 5.5%. But we are seeing an uptick both in our test positivity with electronic lab reporting and with wastewater concentrations. Next slide. And then as far as severity, thankfully we are seeing low severity as far as the hospital admission rates. And the percent of deaths attributed to COVID is still quite low at 0.3%. But again, with this uptick, we'll be watching closely what happens with this summer. And the current dominating circulating variant is Nimbus, and the fastest growing variant is something called XFG or Stratus. And those are still derivatives of the strains that are in our current vaccines. Next slide. And again, just sort of looking at our scenario modeling with our modeling team, and we are looking at potentially a more significant summer wave similar to last year, or a winter wave in 2025 that is more significant, but not two major waves. And as you all know, we had a relatively mild winter COVID activity. So we're still trying to learn about what COVID seasonality is going to look like. And it's been just a little bit different every year. So it's going to continue to evolve, and we'll continue to track it and model and project. But again, we might see a more significant summer wave or a significant winter wave, but probably maybe, you know, our modelers think it's probably just one bigger wave this year as opposed to two. Next slide. So I think this is just sort of summarizing a lot of what I just said. So I'm going to move on to the next slide. And then we just wanted to let you know that we have just updated our reportable disease code as well as of last month. So provider reporting is really restricted just to hospitalizations now, and then lab positive and negative reports are still required reporting, but happen by electronic lab reporting. The prior state public health officer, as far as mandatory reporting, are no longer in force, and the provider reporting requirement is essentially covered under the National Health and Safety Network reporting that we have, and that has been resumed as of last winter, and how we prefer, which makes it easier on all of you as well who are hospitalists to get that data. So that is decided a little bit specifically in local health jurisdictions to providers, but in general, that's how we're looking at hospitalization rates and hospital reporting. So just wanted to update you on that. Next slide. And then finally, this Friday, we are aiming to update a new COVID-19 dashboard that will have summaries and trends, and it'll be updated weekly test positivity, hospitalization data, and death certificate data. So you can see those trends on an ongoing basis. So stay tuned for that. That'll be on our website. And then I know I'm over time, but I'll just quickly highlight what you can look at in our next slides. This is just a small part of the huge cuts happening to public health nationally. I just, as a high level, want to mention that the CDC budget will be cut by over half if the FY26 proposed budget continues to move through. And this is in the appropriations for FY26, which is separate than the policy bill that just got passed. So we anticipate learning more about this in the coming weeks. But for you all to know, 80% of the funding for an organization like CDC goes to state and local health departments. And we in the state health department are probably about 45% of our budget is federal. And then about 2/3 of our funding goes to local health departments in the state. So there's a lot of big changes. These are just a few of the changes that are on this slide. I'm not going to read them to you, but you can use this slide for reference. And then next slide. I just wanted to point out to you, next slide, that the Common Health Coalition, which is a great organization led by actually the Kaiser as a national organization, many health insurance plans, health provider organizations, and public health departments across the country, wrote up a really nice report recently about the impact of public health cuts to healthcare specifically. Because I want to leave a lot of time for the important tick-borne information, I'm not going to go through these slides, but you all can look at both these slide highlights. Next slide. Just showing again that public health impacts your healthcare system as well. Just fewer services, more patients that are going to be sicker and at higher cost, and that there may be some gaps in public health that healthcare providers are going to be forced to fill. Everything from some of the tuberculosis treatment follow-up and some of the other supports and services that we've been able to do that are more upstream or in the community that public health departments have been providing. So really want to just encourage you to keep tracking this as well. And again, I know Medicaid is also really top of mind for all of you, and that is a whole separate topic that if you would all like to get more input on from California, I'm sure we can have that in the future. But I'm hoping that we can work together and have strengthened partnerships together with our healthcare systems, our healthcare insurance companies, healthcare provider organizations, and the departments of public health to work together to figure out how to best continue to serve, especially our rural areas, our underserved communities, and other people that already face barriers to care that are going to get much worse with this current environment. Next slide. And this is just, again, some takeaways stating that as well. Next slide. And I think with that, I will turn it over, but just some acknowledgements here as well. But thank you all for your time, and sorry that I did go over.
Thanks so much, Erica. And just at this time we're particularly grateful to have your voice at our head and then to share this information. Now we're excited to hear from Dr. Ann Kemtrup. As many of you will remember her excellent presentation last session on hantavirus. Dr. Kemtrup is a research scientist and a veterinarian for the CDPH vector-borne disease section, and we're very grateful to have her back today as a subject matter expert for tick-borne diseases. Thanks, Anne.
All right, great to be back. So good afternoon, and thank you for your interest in tick-borne diseases. And today we're going to do an epidemiology clinical tag team. I'm going to focus on what and the numbers, and Dr. Green will focus on clinical aspects. So if we could have our slides up, please, and you can go to the next slide. But first, let's do a quick tick primer. In California, we have over 50 species of ticks, and fortunately, only 7 of these species typically bite humans. On the right, you see images of adult ticks from our popular tick card. The first 4 species are what we call hard ticks because they have a hard outer covering to protect them in the environment. And you can see the female's hard outer covering is much smaller, allowing her to engorge. On the bottom is an image of an adult and nymphal soft tick. These are exactly that. And they live in entirely different habitats where they have to be protected. Next slide. Here are typical hard tick habitats along trails in most moist coastal areas or on wood products like this picnic table where the nymphs like to hide out. Some moisture protection is needed, as you can see, um, and you're not likely to see hard ticks in cityscapes, for example, with the exception on the right of the brown dog tick, which is one that feeds mostly on dogs and can infest backyards or certain environments when dogs are present. Next slide. In contrast, soft ticks need sheltered environments such as rodent nests, and these rodent nests are found high in trees or in nests in grounds and where humans come in contact when rodents build nests in walls, such as in this cabin, and the ticks happily live in the rodent nests. And if the rodents are removed and the nests remain, the ticks quite happily search out people when they sleep on the floor or beds or pushed against the wall. Next slide. California, I like to say, is a mile wide and an inch deep when it comes to tick-borne diseases. We have at least 10 endemic tick-borne diseases, but they occur in focal areas. And so that means our actual human cases are not that high. Next slide. Today, I'm going to focus on the top three: Lyme disease, soft tick relapsing fever, and anaplasmosis. And hit enter, please. And I'm going to give a nod to this zebra, Rocky Mountain spotted fever, which is a disease emerging in Southern California in particular. Next slide. Let's begin with Lyme disease caused by Borrelia burgdorferi. The life cycle in California begins with the early life stages of the western black-legged tick feeding on infected rodents. In the next life stage, as a nymph or adult, you can see they can then pass on the spirochete to another rodent or an unsuspecting human. Deer are not infected, however. They serve as amplifiers of the vector tick because once a tick has a blood meal, she drops to the ground and produces thousands of eggs. Please hit enter. So here's where California is unique. We have our friend, the western fence lizard. This is also pertinent to the alligator lizard as well. And what occurs here is our larval and nymphal ticks prefer actually to feed on this lizard. As you can see, this his little nuchal pouches is what those are called, are filled with ticks. And what the lizard has is a substance in the blood. It's actually related to the complement protein, which is actually Borrelia-cidal to the Borrelia in the tick when an infected tick feeds on it. So we like to call the lizard a zooprophylactic role in California's ecology. But the result of that is in many areas of California, the prevalence of the Borrelia organism in ticks is much lower than what you're going to find in the eastern United States. Next slide. In California, we have about 100 cases of Lyme disease reported each year. And of note, about 30% of our cases are travel related, typically to the eastern US or the upper Midwest. So it is important to consider summertime travel and exposure to ticks, both in giving prevention information to patients and when asking about tick exposure history. Next slide. If we look at our confirmed cases over 10 years, there is a consistent pattern of cases occurring most commonly in the northwest coastal counties, north of the San Francisco Bay Area, and in the Northern California counties with western-facing Sierra slopes. Next slide. This corresponds roughly to where we find the disease organism in ticks in our surveillance efforts, and you can actually access this map online at that link and click on your specific county to see where we've been and what we found. Next slide. Moving to anaplasmosis, also known as granulocytic anaplasmosis, you can see that its life cycle in California looks a lot like the Lyme disease life cycle, and that's because this morula-forming bacteria is carried by the same tick that transmits Lyme disease. So again, the earlier life stages feed on infected rodents who have the organism in their blood, and then in the next life stages, the tick transmits it to either people or other rodents. And again, the deer plays a minimal role in this in terms of transmitting the organism, but it does amplify the tick. We don't have the lizard playing a role here, however. So this is much more of a direct life cycle. Next slide. So anaplasmosis has really been emerging over the 20 years, and we do consider it endemic here in California, though it is important to note that travel is an important risk factor. Again, over 50% of our cases have travel history also related to the upper Midwest or Northeast, where anaplasmosis is more common. Confirmation by PCR is more readily available now, so that's helpful in diagnosis. We get about 6 cases reported each year with a range of 1 to 22, and hotspots are going to be in the north coastal counties, as I'll show you. And we have had 2 reports of Lyme and Anaplasma co-infections acquired in California. And about, let's go to the next slide. So again, this shows you where our cases have been identified in terms of their county of residence. And you can see that, again, you have this preponderance of the north coastal areas, again, reflective of sharing the same tick vector with the Lyme disease organism. Next slide. Jumping over to soft tick relapsing fever, which is Borrelia hermsii and other Borrelia. In contrast, this soft tick relapsing fever is mostly acquired in California. You can see that typically 100% of our cases are exposed in California. Next slide. And where they are exposed is reflective of this soft tick that needs to have a protected environment. We find it commonly in higher elevation counties where the rodents may build nests in cabins and so on. Mono County, unfortunately, takes the case again, along with hantavirus as a high incidence county for this disease. Next slide. I want to highlight some unusual exposure sites we had last year, but they also emphasize where we see this disease. We had one case that was acquired in a glamping location at a lower elevation than we expected. And then we had another one who had an outdoor exposure, which is not as common, where the individual camped near a rodent nest. And then another who acquired it in this fancy multi-story treehouse, but which had fairly easy access to rodents and rodent nests, and we were able to recover ticks from this treehouse. Next slide. Here's my nod to Rocky Mountain spotted fever. We do not see a lot of these cases every year, maybe up to 10 cases. It's difficult to diagnose, recognize, and to confirm. You can see that travel also, out-of-state travel, is an important risk factor for this. Next slide. So though this is an emerging disease, it has been around and endemic in California for a long time. The endemic and more rare form is caused by or carried by the Dermacentor species tick that is shown in the top there, the American dog tick, Pacific coast tick, or the Rocky Mountain wood tick. And that is more related to exposure to wild land areas, like if you're hiking or hunting. So the emerging ecology is carried by the brown dog tick, and this is an important disease emerging in the southwest of the US and in Mexico. And indeed, you can see that 1/3 of our travel-related cases are exposed either in Mexico and 1/3 in the southeast US. You can also note the preponderance of cases with the Southern California residents This is because travel history is really important in these cases. Next slide. Earlier this or last year, we published a case series of severe and fatal Rocky Mountain spotted fever, which was in individuals who were exposed in Tecate, Mexico. That was an emerging area we were not aware of. So this might be an MMWR that might be of interest to have a look at. Next slide. I am in public health, so we have to talk about prevention, but we'll do it rapidly. Next slide. We have a fabulous website that has lots of good information on how to prevent tick-borne diseases, including information specifically for health professionals. We have a California endemic tick-borne diseases at a glance sheet that you may find helpful. Next slide. This is an up close and personal look at it that shows the diseases, who carries it, how many cases we get a year, and kind of the habitats where you can find it. Next slide. We have our ever popular Ticks of California card, which you are free to order from us, and we're happy to provide it. It's a nice resource to see, you know, what tick bit me. A lot of people like that. Next slide. We have toolkits on how to prevent tick bites and what sort of preventive substances you can use to keep yourself safe. Next slide. So we have our conclusions about our 9 to 10 tick-borne diseases. And our areas of risk for Lyme disease and anaplasmosis both include the north coast of California counties and Sierra Nevada counties. And travel is important risk factor for many of our tick-borne diseases. Soft tick relapsing fever is endemic in contrast in these high mountain areas and is associated with sleeping on the ground or in close contact to walls where the ticks emerge at night to feed. And personal protection is always best. Next slide. And you can hit, yes, there we go. And so that is it for my presentation.
Wonderful. Thank you so much. Great information. I'm just going to quickly present to you our next speaker, Dr. Gary Green. And we're very happy to have Dr. Green here, who's board certified in both internal medicine and infectious diseases, has practiced in a variety of settings, and he's currently the medical director of quality for Sutter Health Medical Group of the Redwoods in Northern California. So thanks so much for being here, and we'll dive right in there.
Yeah, thank you very much, everyone, for having me on this talk. This is a very interesting topic. It's a big topic, so luckily you'll have the slides for review afterwards. But I want to kind of give you some clinical pearls and a few pitfalls of Lyme disease. This will be a little bit of a review. Next slide. I do have one disclosure. I am a fellow of the Infectious Disease Society of America. That's important because there are competing guidelines and competing publications on Lyme disease. Next slide. Click once. So in 2021, this came out. It's a combination guideline that was published by the Infectious Disease Society of America. IDSA has been doing guidelines for many things, including pneumonia, sepsis, tick-borne diseases. The first one on Lyme disease came out in 2000. I think this is the fourth reiteration. But in this publication, IDSA reached out to the American Academy of Neurology and the American College of Rheumatology to do these combined guidelines. They're very thorough. They're very evidence-based. And they're by some of the brightest minds in our country in academia, both on the molecular level as well on the clinical level. Next slide. I do want to be kind of transparent and honest. There's a competing guideline. Some people call this an alternative guideline. It's by the group called ILADS, International Lyme and Associated Disease Society. These were published, I think this is their second review that was published in 2014 in a little bit of a different journal, Expert Review Antimicrobial Therapy. These guidelines are not at all overlapping. They're remarkably different. And unfortunately, I think this confuses a lot of primary care docs because they're kind of wondering, how do I approach this disease? And why are there such competing guidelines that give such different recommendations? Next slide. And Leonard Segal was he's a really smart academic molecular biologist as well as academic rheumatologist at Rutgers, and he actually published in 2002 this really interesting point of view on these two different communities that have published guidelines. Next slide. Let me click once. Click again. So rationalists versus empiricists. Rationalists are people who use scientific studies on a molecular clinical basis, develop models of disease. It's an evidence-based approach, and it incorporates Koch's postulates, trying to prove and test causality. So this is kind of what we all think about in traditional medicine. The IDSA uses this. Traditional medical community uses this, much more of an academic um, perspective in science. Next slide. Click twice. And then the empiricists are a little bit different. The empiricists base models on community events. They develop diagnostic and management schemes that are compatible with their observations in their local communities, but often their conclusions are at odds with scientific conclusions. Click once. And this is kind of what's represented by the ILEDS group. The ILEDS group, oftentimes their publications do not prove causality, but they are based more on observations. So these two perspectives on clinical information and clinical data, some of this operational, some of this more traditional science, leads to very different points of view in two different guidelines. What I'm going to present to you today is an IDSA point of view. It's a traditional academic, evidence-based science point of view with regards to Lyme disease. Next slide. My wife is an internist, and she said to me, please go over prophylaxis. So I'm going to front and center just kind of mention that if someone comes in with a tick bite or they report to you a tick bite, what's the IDSA point of view on prophylactic antibiotics? And typically it's a doxycycline dose, 200 milligram single dose in adults, and it's recommended in IDSA guidelines for high-risk tick bites. Well, what represents a high-risk tick bite? A bite by an Ixodes tick that's been attached for at least 36 hours, and it occurs in a highly endemic area. Highly endemic area is defined by nymphal tick prevalence of that spirochete in at least 20%, and we don't have that in California. So California, it's unlikely to get 20% prevalence. So following IDSA guidelines, California's low prevalence doesn't meet the criteria for prophylaxis. But I think on the basis of tick anxiety and people's concern about Lyme disease, a lot of doxycycline gets used within 24 hours after a tick bite. Next slide. I do want to kind of compare the characteristics. We have two different vectors. One Ixodes tick has a 3-year life cycle. The other one has a 2-year life cycle. And kind of showed this really well in the diagrams from CDPH. And I just want to say, if you're in the Northeast or the Midwest and you are in Ixodes scapularis area, the nymphal ticks, 10 to 50% can be infected. The adult ticks, 20 to 40%. Remarkable prevalence of Borrelia burgdorferi in those ticks. Compare that to Ixodes pacificus tick, which has a very different life cycle, looks for different hosts, and the lizard is really key to that. If the tick bites a lizard and that tick happens to be infected with the spirochete, the blood meal from the lizard wipes out the spirochete from the tick. Doesn't hurt the tick, but it wipes out the spirochete. And because of that, our nymphal tick prevalence is about 4 to 6%. A couple studies in Mendocino County showed 20%. One study showed 40%, and the 40% is kind of oftentimes referenced by alternative groups to kind of talk about the prevalence of Lyme disease. But really, in most studies, 4 to 6% of the nymphal ticks in California will be infected. In the adult ticks, about 1.6%. That's very different from the Northeast and the Midwest. Again, Anne mentioned the fence lizard, but ticks are opportunists. They'll go for gray squirrels, they'll go for wood rats. The wood rat is very important because that's actually one of the reservoirs of Borrelia burgdorferi in the wild. And then the adult tick looks for different animals. It doesn't look really for deer. It looks more for smaller mammals and birds. And a lot of my patients will say, I'm really worried. I have so many deer in my yard, and I let them know that it's really not the same deer tick as we see in New England and as well as the Midwest. Transmission is really over 48 hours. And that's some great research done by Bob Lane. And if you notice the references at the bottom, most of these are from Dr. Robert Lane, who was a tick entomologist at UC Berkeley. Next slide. And I just want to say, I want to dedicate this lecture to Robert Lane. I actually met with him once in his office, and I've heard him speak before. He's an exceptional tick entomologist. He really helped us understand the difference of Ixodes pacificus versus Ixodes scapularis. He's the one that really fleshed out the zooprophylaxis of the western fence lizard. Not only that, but he's also taught so many people in the community in biology as well as clinical medicine. So I know he was a mentor of Ann Kendrick as well. So an extraordinary person who managed to stay out of the politics of Lyme disease, which is incredible in itself. Next slide. So as we talk about Lyme disease, I just want to focus on three things. Remember, there's an early localized infection of the tick bite. And so if you're bitten by an Ixodes tick and that tick happens to have Borrelia burgdorferi embedded in its midgut, there's an early localized infection of the tick bite. If you don't get treatment, that can move on to early disseminated. If you don't get treatment, there's a chance that it'll go into late infection. Next slide. Click 4 times. The early localized infection is important. First, you have the tick bite, and you see here at the upper part an embedded tick. There's some erythema around that tick. That is not erythema migrans yet. That's just a reaction, a local reaction to the salivary proteins of the tick. But there's a time in that tick bite. So an engorged tick is important because it takes almost 30 hours for the tick to scissor through the epidermis. And then it takes another part for the salivary proteins to be excreted under the skin. But the spirochete's in the midgut of the tick. So the spirochete has to change its outer surface proteins, move from the midgut into the salivary glands of the tick, and then be exuded with the salivary proteins. That's why it takes 48 hours for tick attachment. If someone comes in hiking, they've had a tick attached, they remove it within a few hours, the chance of that resulting in Lyme disease is exceedingly low. And then in the last one there, you see at a previous tick bite and the tick is gone, you have this expanding ring-like rash. That's erythema migrans. It's sometimes a little bit warm, can be a little bit itchy, typically not tender. Click 3 times. If you don't get treatment for erythema migrans and you don't see it, perhaps it's in the scalp, perhaps you're a darker complexion person and you might not see this bullseye rash because, again, it's not tender, it's sometimes barely itchy. Then you move on to bacteremia or spirochetemia, where the spirochete goes with the bloodstream. This is when you get the fevers, the headache, the myalgias, arthralgias. And then in the last photograph there, you see multiple erythema migrans lesions. This isn't multiple tick bites. Typically, this is when the spirochete goes to the bloodstream and then hematogonously lands in the capillary system of the skin. Click once. In the early disseminated infection, you can have AV node block if there's cardiac involvement, sometimes myopericarditis, but that's much less common. And then you can also get Bell's palsy or lymphocytic meningitis with neuroborreliosis in the early disseminated. If you don't get treatment for that, then you move on to late infection, which most commonly is going to be arthritis. Next slide. So how do you treat early localized versus early disseminated? It's the same antibiotics: doxycycline, amoxicillin, or cefuroxime. One of them not in combination. So doxycycline is most commonly used. Early localized, following IDSA guidelines, 10 days only. Early disseminated, 14 to 21 days. Click again. The first pearl I'm going to share with you guys, if you see early localized infection where there's an erythema migrans lesion at a site of a tick bite, you don't need to do serology. In fact, serology is oftentimes negative because there hasn't been enough time to develop antibodies to the spirochete yet. So serology is not needed for this. You've made the diagnosis by looking at the erythema migrans, and you're all done. Just treat it appropriately. Click again. The second pearl that I'll share with you is that first generation cephalosporins don't work. So if you're given cephalexin because you're kind of afraid that maybe that tick bite has a little bit of cellulitis because this erythema migrans is a little bit tender, you need to use cefuroxime. Cefuroxime is going to cover staph and strep and kill the spirochete. If you're using cephalexin or another first generation cephalosporin, then it's going to miss the spirochete when you're trying to treat the cellulitis. Click again. So neuroborreliosis can happen up to 5% of the time in Lyme disease. This is an East Coast Midwest number. Bell's palsy is really common. A lymphocytic meningitis or radiculopathy. If you have Bell's palsy and you don't have meningitis, no headache, no nuchal rigidity, doxycycline is recommended in the IDSA guidelines, and it's very effective. If you have lymphocytic meningitis, or if you have Bell's palsy with meningitis, typically ceftriaxone is used because of its prevalence and its penetration into the spinal fluid. Click again. Just another pearl. If ever you see bilateral Bell's palsy in a Lyme endemic area, that is almost pathognomonic for neuroborreliosis. Just start the doxycycline or start the ceftriaxone at that point. Next slide. Cardiac involvement can also happen. This is very anecdotal, is that I see more cardiac involvement on the East Coast where I did my residency than I do on the West Coast where I practice now. I see more neurologic or neuroborreliosis on the West Coast. I see more cardiac involvement. In fact, the last 2 cardiac cases I had were people that were in New England and were traveling back after summer vacation. But how do you treat third-degree heart block is the one most commonly here, and typically we use ceftriaxone for that. Click again. The pearl that I'll leave you with here is that these patients do not need a permanent pacer. Typically, when you treat third-degree heart block that's infected with, as a manifestation of Lyme disease, during antibiotic therapy, after a few days, the AV block completely resolves on the antibiotic therapy. Some of these patients may need a temporary pacer if they're syncopal or hypotensive with a third-degree heart block, but oftentimes it resolves on treatment. Next slide. We don't have much time to go over Lyme arthritis, but for Lyme arthritis, even though it's a late dissemination, doxycycline is often the drug of choice for 28 days. If you have refractory Lyme arthritis, the IDSA guidelines recommend IV ceftriaxone for 14 days. Click again. And the pearl here is to tell you that doxycycline is not just an antibiotic. It does have anti-inflammatory properties. Doxycycline is very closely resembles hydroxychloroquine, which is Plaquenil, which is used by rheumatologists. And so if you repeat someone's doxycycline therapy, oftentimes it's like giving someone low-dose Tylenol. The pain gets better because of the anti-inflammatory properties of doxycycline. Next slide. We don't really have time to talk about the subacute encephalopathy, which is really a problem, and it's a very difficult thing to diagnose with Lyme disease, that typically requires spinal fluid analysis. And then the last one there, acrodermatitis chronica metriplicans. That's what happens in New England. I'm sorry, that's what happens in Europe. It's a European dermatologic manifestation of Lyme disease. We rarely see that in the United States. Next slide. I want to talk just briefly about serology. Lyme disease is not a serologic diagnosis. It's adjunctive, and you don't even need it in early localized infection. But traditionally, we use a 2-tier system where you do ELISA, and if that's positive or borderline, you move on to Western blot. There was a C6 ELISA assay that I've often used. It does not need Western blot confirmation, has a slightly lower specificity, but is not less sensitive. And now there's a modified 2-tier test where 2 screening EIAs are used with different platforms, trying to get away from the Western blot testing, which you have to kind of read the Western blot bands. Is it there? Is it not there? And there's some subjectivity to that. But remember, it's not Lyme disease is not a serologic diagnosis. Next slide. In the 2006 guidelines for IDSA, we actually had some recommendations about what not to do. And in these guidelines as well, don't do serologic testing for asymptomatic patients after a tick bite. It's not necessary. Don't routine serologically test children and adults with psychiatric illness or children with developmental behavior disorders. So if you have a kid with ADHD and you're wondering, could that be Lyme disease? There is no overlap there. You don't even need to do serology. In the neurology world, routine serology for Lyme disease is not recommended for ALS, for multiple sclerosis, Parkinson's, dementia, or new onset seizures. And I would add, please do not order routine serology for chronic fatigue, even in a Lyme endemic area, if you don't have specific clinical features of Lyme disease. Also, IgM and IgG persistence at the Western blot does not mean ongoing infection. And there is some misnomer about, I need to continue treating this patient with antibiotics until the Western bands go away, Western blot bands go away. That's really a misnomer. That's mythical. You don't need to do that. Next slide. And in a previous guideline for Lyme disease, I really love this table. It talks about what not to do. You don't need to go. You don't need to give repeated doses of antibiotics. You don't need antibiotic combination therapy. You don't need to pulse dose antibiotics. You don't need to use things like benzidine, penicillin, quinolones, Septra, Flagyl, tinidazole, fluconazole. Those don't work for Borrelia burgdorferi. You don't need to empirically treat babesiosis, especially in California, because it has a different tick vector. Please don't do anything harmful, like don't give Plasmodium vivax purposeful malaria in order to raise a fever. That's called malaria therapy. Please don't give IV ozone. Please don't give IV hydrogen peroxide. Many of these are found on the ILADS guidelines, and the IDESA recommends that they're either not harmful, they're not helpful, or they're harmful. Next slide. And then I want to end with this. This is my last slide showing that there are so many support groups in red versus a prevalence of Lyme disease in New England, in the Midwest, and a little bit in California. There's a huge number of chronic Lyme support groups throughout the country, including areas where there is no Lyme disease or it's very lowly endemic. California is notable there. Click twice. Thank you very much. This is a photo from Maui.
Thank you so much, Dr. Green. And Anne and Erica, if you're still here, if you can just pop back on briefly, all of you have been incredibly helpful. These were all really big topics today, and we got lots of great questions. I wish we had more time for them, but I do want to say this is a meaty topic, and I'm just grateful that you all addressed it with such a scientific and professional way. I'm going to end with one question. Because I'm the moderator, I get time for personal time, but I actually think it's a clinical question that is relevant. So I'm one of those 100 people that had Lyme disease 2 years ago. And I got treatment. I was immediately better. It was magical. And every time I get an achy joint in my old body, I wonder, what is the chance that I got partially treated and now I have late disseminated disease? So Gary, can you just reassure me about that, please? We've talked about this before.
Well, yeah, I mean, as we get older, we all get a little bit more tired and a little bit more achy. I do a lot of outdoor activity, mountain bike, trail hiking as well. Um, and what we know is that, if you have Lyme disease, you can get it again. And that's another pearl, is that just because you have antibodies to it, those antibodies, they might be neutralizing, but they're not protective. So you can't get repeated infections of Lyme disease. And now serology is not helpful at all because your serology represents immune memory. But really, the classic thing of Lyme disease, for example, the aches and the pains, when you get arthritis from Lyme disease, it's typically in the knee. And it's not just arthralgias, it's swelling, it's a joint effusion. Tap that joint, it's a lymphocytic synovial analysis. So we're all going to have aches and pains from time to time. But the characteristics of Lyme disease, remember, it's a pathogenic spirochete, so it's not going to be subtle. If people have a myriad of subtle symptoms, oftentimes that's not Lyme disease, and they're often misdiagnosed.
Great. Thank you so much for that. As always, I wish we had more time, but just a huge thanks to you all, Erica, Anna, and Gary, and everyone listening in. Reminder that you'll get that survey today, so please fill it out if you want your CME, and we'll have the instructions on how to access the recording. So you can also download the slides from this very informative webinar and send the recording to other colleagues who missed it today. Just reminding you, our next session will be September 9th. And we are going to discuss the incredible state-funded program called CalMap, which is a real-time physician-run behavioral health consultation service for primary care and other docs. And we'll also have Dr. Pan back to present an update on some of the emerging things that we started talking about today, if she's still available. So please join us for that, and thanks everyone for being here today.
Thank you very much.
Thank you.